So you've been app specialist for GE as far as I remember.
I was an app specialist, correct. As my kids got older, I always wanted to do applications, but there was a lot of time commitment, travel.
Mhm.
So I kind of waited till my children got older. And then I started as when they only needed my wallet instead of my time. I started doing applications. It was a great experience. You think you're the big fish in your little tiny bowl, and then you get put into the ocean. You really think what you don't know. It's pretty amazing. The leap into a totally different field, even though it's the same, it's really not. It's the business of MRI.
Yeah.
That's where I first realized that this is actually a business, not just taking care of people as well. Um, and I
I know
was
now you don't travel, but it's kind of ironic that you wanted to do apps because of the traveling, and now you're doing remote. So people might associate that remote is also working from different places and from home and things like that. But you actually don't travel. But we touch upon that a little bit later on. One of the things that I'm fascinated about, because you did the apps and you also help Ezra, which is a massive company that a lot of people probably are aware of. They do whole body MRIs, and you actually help them as well develop their whole body protocol. So you have such a vast experience. You didn't just land on remote. You had a lot
yeah,
of things before that that actually built what you are today. Can you tell us a little bit about that Ezra experience as well?
sure, that was a great experience. So I was working with RadNet, Dr. Tannenbaum, and 𝐒𝐞 came to RadNet and wanted to create this novel approach to cancer, to helping people with cancer, early detection. And I thought, what a great idea. And so I was really gung ho about doing this. And we developed a protocol covering 11 essential organs and the head, the spine, including prostate. Um, it was a really great opportunity, and I know it's helped a lot of people. I've had the test done myself, actually. I believe in it.
You
Uh,
wouldn't be a radiographer if you didn't.
that's right. We've all jumped in the magnet once or twice, right? Um, so
I like when this question comes from patient. How do they test this magnet? How do they test this scanner? It's like, well, here we go. Here I am.
It's
yeah,
very
I've been a guinea pig quite a bit. So that was the Ezra experience. What a great experience it was, and still is actually. I'm very close to Emmy as well. Um, just a fantastic job that they're doing, and now they joined forces, and they're getting it down to $500 a scan, and I think everybody can afford that, and I think that they're really staying on target with what they're doing.
Yeah, preventative medicine is something that me and Julian, we just did a podcast on that, actually, and it's live now on Spotify, YouTube, whatever. We're actually going to do another one related to that topic, because I think preventative medicine, whole body, is something there. It's all over the place as well, like remote scanning. So one of the things that intrigued me is you did bricklayering, then you did apps, then you did Ezra, then you did managing. How did you and your colleagues came to this idea of founding 𝐓𝐴𝐻 when nobody was talking about remote scanning? Because you guys were the pioneers, I believe, in US in terms of offering a remote operation as a service. I think you were the first company, as far as I'm aware. How do you guys come to that from all that you've just described?
That's a great question. I mean, every job that I've had kind of led me to down this path. Each one just being another stepping stone to get to where I am today, and who knows where I'm going to be tomorrow. But I saw the need as we were watching doing the Rock application at my work. I just saw the need for this for not just big imaging centers to do in house, but for the mom and pop places that are strapped for people to work or need the guidance of a expert radiographer or MRI technologist, as we say in the United States. Um, so I just thought it would be a great opportunity, and that door has not been opened yet. And I always like pushing the boundaries if I can. So we decided to start this company. My co-founders, Neil Huber, Ryan Huber, and Dr. Satinder Reiki. we sat down and we developed the road, paved the road for everybody else to go down for the remote. There was a lot of what ifs.
It's important to that you mentioned as well, Pete, that I don't think most people know, but you guys founded this company and you didn't scan the first patient for like 3 years or something like that. Can you tell
About
us
2.5 years, yeah.
why and what that experience felt like?
Well, we wanted to make sure that we were safe first. We did not want to hurt anyone. That was our primary goal. We got in this, it is a business, but we got in to help people. And we wanted to make sure that, we're not going to hurt anybody doing this. So basically, we just brainstormed for 2 years and thought of every possible scenario that could happen on site. And we thought of several different answers of how to fix it. It's not just one, because as you know, one answer is not good enough. You should have several as backup. So one of the primary things that we saw was a problem in the beginning is who's going to be the level 2 person on site in zone 3. There isn't really, if you take the technologist away, there's really no one. So we created a school for technologist aides, MR tech aides, to help them understand the safety and the importance of being safe in the MRI zones, zone 3 and zone 4 especially.
We'll talk about the zone 3 and we'll talk about some of your methods and this new role and everything. But for me and Julian, we are also entrepreneurs. We're also started this company together. And at least for me, I don't know about you, Julian, but for me, it's kind of fascinating how you, during 2 years, didn't actually sell anything and you were just there working on the background, just trying to build something that you had a vision that one day will work, while all of us were completely oblivious of remote scanning. We're just doing our normal day lives, not even thinking there was a possibility. And you guys spent 2 years just preparing for it. So I believe there's more people in this room or watching this later on that will have the feeling that they want to create something as well in the radiology world. Do you have any advice for those people? Like anything that you feel like made a difference for you?
Yes, I do actually. Everybody thinks it's you jump in and it's just going to work right away, and you're going to find that a lot of doors are shut, or you fall down a lot, and you just have to keep getting back up and keep knocking on the doors until they open. Especially with the novel approach to MRI, where people are doing, the easiest answer is no, that's not safe, or we don't want to do that. And then they're realizing the benefits of remote scanning far outseed the risks, and the way that you approach it, well thought out, is much better than just saying, hey, I'm going to start a company today and just start, and then we'll figure out the mistakes as we go. We tried to figure out the mistakes before we went, and it helped us go down the road a little bit easier.
I think
It was a rough road to get down. So
Pete, can I ask you one thing? How challenging it is to go against the "we always done it this way" mentality? Because this is one of the things that we see the most, I guess, in many fields, but radiology, MRI, it's quite difficult sometimes, even for a business, like, to kind of like try to offer what you're trying to do, because you tend to meet a lot of people that will just tell you, oh, we always done this way, we prefer to do this, we prefer to do that. Is that a way, like any kind of like advice you would like to give for this?
that's actually an inspiration when people said we've always done it this way. I take that as an inspiration to do better, to go further. I listen. Some of the best things that I've ever learned were from students. I love working with students. I love helping them because it's really a give and take with them. It's not just a give. They do learn, and they do make you stay on your toes about what you're teaching. So that really helped me, and I always try to push the boundaries of we always done it this way is not good enough for me. So
Lovely answer.
I think we need more people like that, because if we always keep doing the same thing over and over again, we're not going to go anywhere. So that's what me and Julian tried to do as well. We're trying to change a little bit the paradigm and make education a little bit more accessible to everyone. And one of the things that I find parallelism with your story and ours is you spent 2 years without selling anything, just hustling, right? And me and Julian,
correct.
2 years last month in this, just working on the background and trying to bring as much as possible to everyone, because I think that's the key for moving the environment forward, like the MRI environment forwards in terms of educational content. So thank you for what you've done for remote scanning, because I think without what you guys at 𝐓𝐴RT have been doing,
Yeah.
we wouldn't be where we are at this point. And you actually were one of the first companies that I've ever heard about remote scanning, was 𝐓𝐴RT. I remember watching what's the name? It was a podcast with Nathan Smith, and he was talking about 𝐓𝐴RT. And I was like, oh,
Yeah.
what is 𝐓𝐴RT? So I couldn't even find your website, because your website wasn't 𝐓𝐴RT, it was remotescanning.com or something like that.
Yeah.
And
Correct.
I struggled to find it, but when I found it, it was like, okay, I will be doing this in the future. And since then, it's been through the rabbit hole, and
Yeah, it's the present now. It's already the present.
Exactly. We are today after so long. So awesome. We have a little bit of introductions. We know who you are, what you've been doing, what are you up to now. So I would like to delve into remote, actually, per se. You guys, so I have a few things that me and Julian would like to talk to you. One of them is the timeout method that you guys have. We'll touch upon that, because I think it's extremely important for everyone to know what it is. And we should be doing that even if it's not a remote operation. So kudos to you, because that's an amazing approach. And then we have the school that you guys founded as well for the 𝐞𝐸, which is extremely important. It's one of the most common questions that we have is in terms of safety, who oversees the patient and all of that. So that's also important. And then, of course, there's questions most of the times in terms, how can I find a job as a remote operator? Can I work from United States to Italy or to Portugal? So we're going to touch upon these things. From now, my first question is, from your perspective, do you think remote scanning has changed the MRI world in terms of how patients see it as well? We often forget the patient side. We talk a lot about the companies that sell the service, the radiographers that work from home, but we never talk about the patient side. And you deal with this every day. So from your patient's perspective, did it change anything for them? Do you believe it's a big shift in the way we see our patients on a day-to-day basis?
I do actually. There's a two-part to this question. First, the business part of it, and then the second is the patient care. I believe with the bifurcated role now, that the technologists are just concentrating on the scans and making sure that they're quality coming out. And the tech aid also has a little bit more time than the tech could afford to spend with the patient. So we're getting back to the way it used to be, where we can sit and let the patient empty their tank and tell us everything about them and not have to rush them through again. It's only a matter of 5 minutes that got kind of nipped off of the patient care. But I think they really feel more attention now. They're not just a number going through the magnet. And the tech aid can relay that to us as well, so we can stay concentrated on the task at hand, but they still get the care that they need as well. We forget about the care part, healthcare.
Absolutely. Yeah.
Yeah, and it always was very disappointing when I went around the country and saw that. It was more the me factor than it was the you factor, and I think that's going to bring this back full circle to making sure that the care is back in healthcare.
That's awesome, because I think that's one of the things most people are worried about, is like that lack of interaction with the patient and the caring part. So let's say you have a claustrophobic patient, or you have someone with neurodiversity, autism, or anything like that, and is there the support is there for them. What you're telling us is you have that school where you train these tech aides, just so everyone understands. The tech aide is a person that is going to be on the scanner room 3, right? Let's zone 3, the scanner control room, and we'll deal with the patient. So what is the role overall of this tech aide? I think tech aide is a nomenclature that you guys created and you're using. There's other names, I'm sure. For example, I think Anton is on the call as well. And Anton, they have another name in Germany, which is absolutely normal. And we have another name in Portugal. But the point is, what is the role of that person with 𝐓𝐴RT training?
So the role of that person is, first of all, safety, right? So they become level 2 certified in zone 3. The second part of it, and the people that get into this are usually front desk people or EMTs. that they really have like a desire to help people. I've noticed the trend that the people that are actually looking to further their career. So I really find that the tech aides are really speaking to the patients, really listening. Whereas opposed, not that we weren't, but we are under time constraints, so we can only hear a little bit, like I said before, and then kind of have to move on and like kind of move them while we're talking. So I think that the tech aide or the in-suite assistant or whatever you could call them has really brought back the care part, like I said before, to MRI. It's not just a revolving door, and it really helps the patient at ease. We have tech aides go in the room, hold hands of the patients. I've done that for years in my of my career. I've been in the magnet standing on the side of the patient while other people were scanning. It's just part of the job, the compassion part. And I think for all the tech aides that I've worked with, at least, they really do show a lot of compassion, and I'm really proud to work with them. Actually, it's been a good experience. I didn't know how I would feel about it at first, but after like interacting with them, and it kind of just revives my spark in helping people again. I really see the energy that they have with the patients, and it's been positive.
You
That's
mentioned
very nice.
you mentioned something that I think will spark some friction. Let's put it that way. I think that's the word that I'm looking for, which is the tech aide can be someone that comes, for example, from the admin side of it, or it can be, for example, a nurse, or it can be someone that is not actually a radiographer or an MRI radiographer. We had this discussion before because, for example, in Brazil, they use nurses, sometimes biomedical staff. In other countries, they can use an X-ray tech or a CT tech. I believe there's a lot of people that still feel like it shouldn't be that way because that person doesn't have the knowledge about MRI to be there. What is, if you can resume in a few words, what's your feelings about that? And how the syllabus of your training for tech aides actually allows these people to have the knowledge and the skill to be there to do the role that a normally radiographer would do.
Well, communication is actually the key with this between the MRI technologist and the tech aide for every little thing. The technologist is definitely in charge of the situation and can verbally communicate that to the tech aide. So there's guidance there. But with the school, they have enough education to make sure that they're safe. Every tech aide that I work with are changed in people completely, which I don't always see everywhere else. You can probably attest to this as well. I think they're really going back to the basics of what we're supposed to be doing, and they're following it better. I really think it's a positive way to approach MRI, actually, with the bifurcated role.
Yeah, I agree 100%. We have a question from Anton, actually. He's been very active, which is good. Thank you, Anton. He's asking how many people do you have on site per scanner in US? Because I know the ACR manual actually is a bit contradicting there. They ask for 2 people. And how many do you normally have in an operation?
So it's usually 1 person to 2 people. We've had 2 people if they're not rad site approved. But it's usually one tech aide to 1 MRI technologist. So there's
you
two of us.
1 tech aide per patient. Let's put it that way.
Correct. Absolutely.
Yeah.
We would not do it. In fact, we had a customer that wanted to do two MRI units with 1 tech aide, and we did not do it. And they were willing to pay for it. But still,
they didn't do it because it didn't work in terms of workflow, or because you guys did a risk assessment and in terms of safety it didn't make sense?
it was all safety. The money was not an issue. Safety is our primary goal.
Yeah,
and if we did not believe it was safe, we did not do it.
I think we see many instances nowadays that we'll have this discussion actually. I think in one of the other session that there is perhaps the feeling is that there might be the risk to compromise safety. And even if you say, "Oh, I will be there, I can put I can put an eye, I will just hear if something happened, if the patient is gonna squeeze the buzzer," but still, the lack of people, you cannot be like one person like controlling three scanners at the same time, because what is going to happen is that you won't be proactive enough, to respond to a potential crisis or an emergency. So I completely, you have my full support about this, and well done actually for not taking the opportunity. And because I guess when you're a business, every customer represents an opportunity, but try not to compromise safety. This is absolutely the gold standard. Well done, Pete.
Yeah, we are a business, but we're also a movement per se. I think this is the road again, paving and being in the forefront, at least as a third party provider, that we really came in this with a passion to help people. That was my primary goal, and to make sure that we help them safely. It wasn't really about the money to me. It was more about how we're doing this novel approach to MRI, staying on the cutting edge and providing a safe pathway to do it.
I have another question, Pete, and this is also for Summer as well, because now that you're mentioning the Take It, is opening like a completely new window in my brain, and I started thinking, wow, this is quite nice actually. But at the same time, I feel a little bit the concerns of people not having like a radiographer performing these tasks, and I think this also arises a little bit from a lack of indications and guidelines. Is there something at the moment that you know? on a specific country like the US indicates who's this person needs to be, like the person on site. Does it need to be a radiographer? Can it be someone else? Because it seems like even between countries, we receive like mixed information. So I do understand why people feel a little bit lost about this, and I have a lot of questions.
Well, I don't think the governing bodies right now are together in their answer to that. I think it's coming. I think they're shedding more light on this problem, if you will. It's really not a problem, but uh, this approach to doing MRI. So the guidelines are coming. We just wanted to address those guidelines before we even started. So I think we did a pretty good job in those. We spent those 2 years investing in our think tank, basically, to make sure that we addressed every situation, and everything's been positive so far.
I agree with you, Pete, and I understand Julian's question because on ACR manual, MHRA, they mentioned remote scanning. Today, actually, I posted on our worldwide forum for remote operations on LinkedIn that the Brazilian College of Radiologists also published some directives for remote scanning. And all of them mentioned the same thing, that the person doing the safety needs to be level 2 trained, right? But there's nothing about the background of that person, to the question that Julian just asked. There's nothing there in any of the documents, in any of the guidelines or anything saying the person or decade or whatever they call it must have level 2, but the background must be this and that. That doesn't exist. And that's exactly, Julian, to your question, that's what creates a lot of confusion, because as Anton asked, what's the background of the person? Because in Germany it might be a nurse. In Portugal, if we say that a nurse will do that job, with that, people are going to kill us because they hate that. So we need to be very careful with the way we label these things. I know legislation is coming. I know there's a document coming by the end of the year, and I'm almost 100% sure that this will be mentioned there. So just so everyone is aware, Q4, I guess I can guarantee, because I'm not involved in
Do you
it.
think this document sum will be applicable mainly in the US, or the idea is to have it like as a sort of Bible to be applied
It's gonna be international. It's gonna be
international?
international.
Okay,
That's what I
that's
can say at the
that's
moment. It's gonna be an international kind of guideline, but again, it's a guideline. So
yeah.
imagine you are in Italy, Julian. Now you're working in UK, but it works as well. That document comes out, and people in US decide to follow. You in UK decide not to follow it, and people in Italy don't want to follow it as well. But me in Portugal, I will follow it. So everyone will decide. It's the same thing with the ACR manual and the MHRA guidelines and things like that. People decide to follow or not. For example, in Portugal, from the experience I've been having here since I came back, there's a lot of hospitals that follow the ACR manual. A lot of them follow
Oh,
MIT.
yeah.
Some of them don't
Yeah.
follow anything. It's a complete mess. So I think it's going to be the same thing. The guidelines
Yeah.
will be there. They're going to be international, but it's up to the country, to the manager of the certain hospital to actually follow those guidelines or not. I don't know if you agree with that, Pete, but I think that's how it
No,
is.
I absolutely do. And forums like Everything MRI and these talks that were in the podcast that you're doing, these are all forms of communication that need to be done, and speak about this. These are guidelines that they're giving us, not instructions. So we need to make sure that the guidelines are productive and safe the way that they're prescribing. And the only way to do that is to communicate like we're doing now. I've met you in the last year, and we've done quite a bit looking over the ACR and guidelines and stuff. And, this is ongoing, a work in progress, if you will, by everyone. And the way to do this is to communicate. I've met some great people along the way. Doug Boyd, Tobias Gilk, there's a lot of people, John Rena, that are really pushing for the safety and advocacy of not only just remote scanning, but scanning in general, which has to become safer in and of itself as well. As you can see, the wheelchair picture is always it's still happening. So when that's, I guess we can start, looking down other roads, but it hasn't stopped yet.
I think actually Neil Gunn gave like a very interesting assist because she said in one of the comments, I have great respect for nurses, admin people, receiving training in safety and so on, but this is part of our profession as a radiographer. Isn't that something we should cherish more, keep our job duties? And I do understand where it comes from, but at the same time, I also think, and correct me if I'm wrong, Pete, in some countries more than others, there is also a lack of radiographers. So not being able, to provide that service because you're not able to find enough radiographers, perhaps will be more like affecting the patient itself rather than us, meaning like potentially losing some, I don't want to say skills, but potentially like some job vacancies or whatever in advance to some nurses. So I would say it's like patient care will be prioritized in some countries.
Yes. So I believe that the most expensive and the most non-helping MRI unit is one that's not being used. So with the lack of radiographers or MRI technologists, their doors are shutting. So they're not. So that person now that has to just drive 5 minutes to their house now has to drive an hour. They might say, you know what, I'm not going to get my test today. And maybe they really did need that test. There was a lesion on their liver that they kind of just blew off now that there's not close enough imaging centers to provide them the service. That's one thing. Everything new in any kind of imaging has always been at first looked down upon, right? I remember when they were doing orthograms and stuff in MRI, and it's like, oh no, or biopsies, prostate biopsies, that's not going to take off, and it did. So there's been a lot of novel approaches to MRI over the last 30 years that people said that it was not going to work, and it actually did. I think you just have to keep an open mind and again communicate. And I think this is great when people say that they're concerned. They should be. Everybody should be concerned about your patients. I still am concerned every day as I work.
It means that you care, Pete, right?
Yeah, I mean that's what I got into this for. I still get my hair still stands up on my arms when I'm.
Yeah.
Guys, we look inside people's bodies for a living. How amazing is that? I mean, we're the first people to see either they're getting better or the first time that that this person has cancer and stuff. I mean, it's just amazing what we do for a living.
Absolutely. I just want to
still
add
get very.
one thing. I want to add one thing as well because Diogo also mentioned that he agrees because in Portugal we have such a high number of radiographers that it could feel odd to give those jobs to other professions. That's what I was saying as well. But again, going back to the first webinar, this is the fourth one. On my presentation, I was already mentioning that remote operations are not for everyone. They are for those who need it. And that goes exactly in tandem with this because in the United States, we actually need it. So there's a lack of staff. So as Julian is saying, instead of not providing that scanner to the patient because we don't want a nurse or an admin person to be the tech aide, we're going to do that so we can provide that scanner to that patient, so we can provide that diagnosis and maybe treat them. So I think it's a balance. We need to find that balance between actually helping our patients or not helping our patients. So some countries will struggle with this a little bit more than others. For example, in Portugal, I don't think we need remote scanning as a service. We need remote scanning as a way of reaching, for example, rural areas. I don't know about your experience, Pete, if you have that in the United States, where you have areas in, for example, Florida, where you're based, that there's no access to an MRI or there's no access to a specific scan like cardiac, prostate, whatever. And remote can help on that. So that's how I see remote operations actually fitting in some European countries like Portugal and Italy. So that's just to answer to the as well. But yeah, I wanna share something. I've shared this before, and I wanna, not this specific one, but I wanna share a picture about, so we can talk about safety and we can talk about the method that you have, Pete, at 𝐓𝐴𝐷 that you guys developed. So I'm just gonna put that picture on the screen. Give me 1 second so I can put it big so everyone can see. This is part of a diagram that I've been building for a while just about remote operations. So I hope everyone can see this one. So this one is just an example of a zone 3 preparation kind of room where we need to make decisions. So zone 3 is where we make those decisions, the big ones. And Pete can attest to this with the method that he's going to explain to us. So I'm going to give a scenario, and I know there's a person already. I'm sorry I didn't memorize your name, but I'll come back for that, on the questions asking about contrast. So this is the perfect example because that's the one that comes most often to us. So let's imagine we have a patient, he went to zone 1, zone 2, we are now in zone 3. I know some countries don't have zone definitions, for example, Portugal is one of them. So when we get to this zone 3, which is the prep room or control area most of the times, we have a decision to make. So that decision should be made by patient, radiologist, on-site operator, and remote operator. And in these cases, are we giving contrast or not? Okay, so if you don't give contrast, okay, no cannulation, so clinical pause here, exam proceeds without GAD or patient rebooked. So if it's to rebook, goes back to the admin area. If it's not to rebook, we just keep going with the patient to zone 4 where we do the scan. And then, of course, before the patient goes into the scanner, we have another safety check with the remote operator. So Pete, my question to you, you have this method that you guys developed, 𝐓𝐴𝐷. How does that method fit within this diagram here on zone 3, where we have to make these decisions about safety? I'm cannulating a patient, I'm not cannulating a patient, I'm giving GAD, I'm not giving GAD. Patient has an implant, should we go ahead or not? How does the timeout method work and what is it?
Great question. So our timeout is what we developed in those 2 years of not working, just paving the road. This is a safety check, which we all do. So the screening form is filled out. The remote technologist can look at the screening form as well as the MR tech aide, MRTA, or in-suite assistant, whatever you want to call them. So there are 2 sets of eyes are on the paperwork. Then the tech aide verbally screens the patient like we would normally. And then comes back to the technologist and relays the information in the timeout that we do, where we can stop the exam at any time, thinking if it's not safe. If we think it's not safe, we will stop and get managers or the doctor, MRMD, on site to further investigate or go or no go with the patient. I think we've caught a lot of implants. With the bifurcated role and then 2 sets of people's eyes on the paperwork as well as communicating. It's been a better experience, I think, personally, as far as safety, because now you have 2 people looking at your paperwork, 2 people discussing your issues or your implants. So I think with that, it's been a safer procedure, MRI procedure. We haven't had any issues
for example,
so
I
far.
swapped this contrast decision here that I have here, and I put an implant, which you were just mentioning. basically I'm missing here on this diagram the MRSO or MRMD to make that decision. For example, if I'm talking about an implant, so that decision will fall around this area where you do the timeout and you discuss the local technologies discuss that with the remote, and then they involve the MRMD or MRSO to decide are we scanning or not scanning that patient. Is there a fair?
That's very fair. That's exactly what we do. We provide as much information as we can to the MRSO or the MRMD. I am an MRSO as well, but not for the site. But I'm willing to help as always. So I try to get as much information as I can and then hand it to the MRSO so they can make an educated decision with the MRMD about whether we proceed with the procedure or not.
So I have two compound questions on that. So let's say the remote technologies at home, are they normally MRSOs or not? And the tech aids, can they be MRSOs as well? I think they are, but I'll let you answer that. So that's the two questions. Can both ends be MRSOs? And how that communication works in terms of GDPR. For example, if you want to send some patient information out to the remote operator, there's a lot of conversation about where is the data of the patient. Is it stored somewhere? Is there a risk? So those are the two questions. If both of them can be MRSOs, and how it works with, for example, you were saying that the local does the safety questionnaire and then shares it with the remote. How does the remote actually talks to the patient or just reads the document? How does that part work?
So the remote person really does not speak with the patient per se. They can if they come into the screen and the audio box is on. I have spoken to patients as a remote scanner, but it's more communication to the tech aide with what we're going to do. They relay the information to me. I digest it, and then if I think I need more help with the implant, I will reach out to the manager or the MRMD or MRSO that's dictated for that specific site, and then we go from there. We communicate, and we either decide we're going to do the exam or we're not going to do the exam. We have the right to refuse the exam if we don't think it's safe. We always make sure that is one of our primary goals in there. We don't want to turn anybody away, but we don't want to hurt anybody either. So if there's any reasonable doubt that the patient might be hurt in some capacity or other, we either get other people involved or we just don't do the test.
So you are the extra layer of protection, let's say, like before like the final decision, let's say.
Correct. So we want basically it's always going to fall on the MRMD. Having said that, we want to make sure that they have all the information that was given to us so they can make an educated decision about this patient.
Yeah.
As far as contrast is concerned, contrast in the United States is really dictated by the script and the insurance. If the doctor deems it's necessary, the patient will be then given contrast, but that's not for an MRI technologist or tech aide to make that decision. Not here in the United States, at least. That's how we scan, even remote or regular. We're dictated.
It's good I mentioned that because Isaac, I'm sorry, Isaac, I didn't remember your name. That's where he was asking what role does the tech aid play in patients with contrast-induced anaphylactic or if they have like a unresponsive patient midway. Are these tech aids actually trained to respond to these kind of situations?
So yes, part of the training is there's an emergency response part of the training, which they do on site as well, just like the technologists do. Once or twice a year they'll practice a code, and then codes can be run as practice for the MR tech aides as well. We are not giving any kind of drugs or anything. Neither is the technologist. That's for a doctor to do. As far as at least in the United States, I can't answer for Portugal or England or anything, unless the doctor is right there telling us what to do and giving. But it's mainly the doctors that give the drugs. We don't do that. Yeah. We perform CPR if we have to. All the tech aides are CPRs certified as well, just like a technologist would be. Um, so that's basically how we do everything. Contrast is not given by the tech aide. It's usually given by either another technologist, could be a CT tech or an RT, or the doctor. I've had doctors go in and inject as we're scanning.
Peter, what about if the tech aide is a nurse? Are they allowed to inject contrast or?
Well, that's really regulated by the state and the imaging center. So I would think that a nurse, a qualified nurse, would probably be able to do it. Again, we have to refer to the state that we're going, the state rules and the imaging center rules. So it's really different for each site.
Yeah,
Makes sense. Yeah, and it's
And again,
different.
this is a new approach to MRI, right? So these little things, these nuances that are happening are getting evaluated and then becoming, you know, experience and decisions that can be made for further use down the road.
I think overall is one of the biggest problems is that lack of standardization, because not at the state level but at country level, everything is different. If you go to, for example, we were speaking to Martin in Germany, and then we spoke to Zoe in Australia, and now we're talking to you in US. So we went basically across the world, and all of you told us slightly different things within the same realm of remote scanning. So I think that's one of the issues as well, because people struggle a lot because everyone comes from different countries telling them this is how it's done. But then you come from Australia, no, this is how it's done, you know? And because there's no standardization across the globe, we're gonna hear an opinion that I give as a Portuguese radiographer, worked in London for 13 years. I have a certain experience. But if I talk to you, Pete, you come from the United States, you work 33 years there, it's completely different. So when I'm in the middle of this and getting information from everywhere, I don't know what's real, what's not real, what is actually happening, if it's safe, it's not safe. I think one of the reasons that we wanted to do this, me and Julian, is we get people from across the globe to tell everyone how it's going and show that it's actually more or less the same. And it's all about just guidelines or nomenclature or tiny details. And as Anthony saying here on the chat as well, we're here for the patients, as you said, Pete, as well. The most important thing that we do is for the patients. So if we go back a few episodes as well, and when we move forward to the next episodes, we can all see that there's a parallel line towards everyone that we talk to. We care about the patients. We care about the safety, and everything we do is towards that goal. So I think that that's one of the things that makes it hard for people to accept remote scanning. It's the lack of standardization in terms of names and procedures and workflows. I don't know. What do you think about it? You think that's also true for you?
I don't think that people are against remote scanning. I just don't think they know enough about it right now. And I think with forums like what you're doing with your podcast and everything MRI, this really opens up the communication. So people that are on this that were maybe against it, maybe they've turned their idea, or at least have an open mind about it after us speaking and everyone talking about it. This is how things change, right? This is communication. If we don't have the communication, not only between countries, between the world. I mean, the world has gotten a lot smaller with podcasts and social media. So it's not just a United States problem or a Portugal problem. It's worldwide. And like you said, everybody's just a little bit different, but we're all kind of carrying the same message. So when we communicate like this, and kudos to you guys for doing this, because this is how it starts, right? It gets people to think, and then
That's the
so now
whole.
they're educated about it, or at least starting to be educated, and then they further pursue it and help the cause. Whether it be remote or something new that comes down the line 10 years from now.
Absolutely.
This happens to be the thing right now.
Absolutely. And if I can add just a tiny little thing to what you're saying, to support what you're both saying, is that differences in healthcare that has always been, and I can bring my example. I remember working back home in Italy, we were always relying on a nurse for injecting the contrast or a doctor. And then, it was always like a shared environment, among different professionals. And then coming to the UK, suddenly I found out that the radiographer or the tech, the MR tech, is completely in charge. You inject contrast, you cannulate, you do all these tasks that in Italy were like sort of like a dream, like that was mainly competence of the nurse. I'm not gonna touch the patient, of course. So, differences there has always been. And I think same is gonna apply to remote scanning. We're gonna see, people doing different things in different parts of the world, but it is exactly as you say. In the end, what matters the most is patient care. So we need to use it in the right way for the patient.
Absolutely. And that's the bottom line with any novel approach to helping any kind of imaging is make sure that you're helping the patient in a safe manner.
Pete, changing gears a little bit. One of the things that I know people are very keen, because you have that side of the room where they're like still a bit skeptic about this, but then you have those that love it. They want to work on it. They want to jump on the train today. So how can people get a job as a remote operator if they are, for example, in Florida, or if they are in the United States in general? How does that work with you guys, the hiring process?
Well, one way they can visit our website, and as we grow, we're building as well. I've met a lot of great people across the United States that are ready to jump in this. Sherry from Illinois, Frank from Naples, Joe from Texas. We have a lot of people that are ready to jump on this big wave that's coming. For us, you can just go to our website and apply. We do like we do it like a little test for the patient, for the technologist. It's not like a physics test or anything. It's more like identifying artifacts, or how would you handle this situation real time, just to make sure that they're not too novice to do this, because it is very intense when you're scanning 2 or 3 patients at a time, mainly 2, but sometimes the 3 happens. You still really have to be. It's labor intense, and you have to know your MRI skills have to be up there. I don't recommend this for new technologists. I think they should get some experience with the patient and know what the tech aid is going through.
It's good.
Or I think you'll have the compassion.
It's good that you touched that point, Pete, because some radiographers, let's say remote scanning is coming, right? Is whatever in many countries already, but some schools are already opening their eyes for that reality. So some students are already coming out of university thinking, I'm going to be a remote operator. I don't want to work at the hospital. Do you think that's going to be a problem? Do you think that students that get out of university and get a job straight away in remote operations will lack some kind of empathy towards what they're doing because they actually never dealt with a patient? They're just looking at a screen. Do you think that's going to be an issue?
So in my opinion, and this is my opinion, I think that that could happen. That might just me being old school. But I try to keep an open mind to everything. Again, like I said before, I've learned a lot off students and over the years. So I don't want to say that it would, but I don't know how the new generation kind of will take it, and maybe if we feed them the information about being compassionate, and they'll identify with the patient as well.
The reason I'm asking you this, Pete, is it's not a problem, but I have some kind of friction with the university side, because I did this poll and I've been talking about this in lectures. I spoke about this in Vegas, actually. You probably remember that.
I remember.
There's a lack of safety training at university level. So if there's a lack of safety training at university level, and we get these students getting out of university straight to a remote scanning job without patient contact, so they will lack safety knowledge, they will lack in empathy towards that patient because it's an image on the screen. From my perspective, and I agree with you, I think we shouldn't get these novice radiographers into remote scanning. I believe, and I agree with you, that we should get them first at the hospital. But I'm saying this to ask you a question. So my question is, how do you actually train the remote operator? Because working from home and working from a hub, working from a command center, it's very different than actually scanning at the hospital. It is very different.
Correct.
So how do you train them as well? Because they actually need training too.
Correct. First part of that is it's an analogous to the drone fighter, right? They go in and they fly their drones and they drop their bombs and they go home and they're living in Las Vegas or wherever they are, without really knowing what they just did. So I think the experience, as far as the technologists being there, watching a patient cry and holding their hand while they're crying, you can't teach that. You have to experience it. That has to be experienced in order to become compassionate or not. As far as this safety is concerned, safety for scanning, whether it be remote, albeit or on site, the safety is still not there. I think the schools are recognizing it now. I know the governing bodies are, the ARMRIT, ASRT. They're going to make safety a class. So I think people like Tobias Gillick has been pushing the safety efficacy, as well as yourself and people like Doug Boyd and everyone, as far as safety is concerned. So I think that's going to be recognized and fixed in the university level. So that should not be an issue coming up. As far as training technologists, we do ghosting methods as far as new machines. We show them by watching and then training them. So we try to make an agnostic technologist, vendor agnostic. So we do provide training for them, adequate training before we set them up on our own. We don't send anybody up for failure. We make sure that they're comfortable.
Of course.
Whether I have to spend 20 hours with you right behind you.
There was another question about this, because you're saying they are vendor agnostic, right? So they can scan basically on anything. But also we have to have in mind that it's just not nowadays, because let me rewind a little bit so everyone understands my point. So when we are radiographers, we come to a hospital, we normally work Siemens or GE or Philips, whatever. And then we eventually work with another scanner. So we are kind of vendor agnostic, right? But now when we are remote, it's a double entendre, because we have Philips, Siemens, and GE. We can work on those. But then we have platforms, remote platforms. So we have to learn remote platforms, because Alpha, I don't know what platform you use, that's fine. But imagine you probably use Rock from Philips on site.
We use multiple, actually.
Exactly. Yeah. So instead of learning 3 scanners, now I need to learn 3 scanners and 4 platforms. So this breed of radiography is a very different breed than what we're used to. Because we used to, okay, I've worked in Siemens all my life, now I'm transitioning to GE, it's a little bit difficult. We need to be in a faster pace, because I need to know Siemens, Philips, 𝐓𝐡𝐞, Canon, whatever, and I need to know Ionic Health platform. We scan from Siemens, Rock, Go Club. We need to know platforms on top of scanners. Do you think this is a challenge as well?
Yes, absolutely. It's a challenge. And this is, again, like you said, this is not for everyone. People that like to be challenged in their day-to-day life, this is very good for them. They like to learn new things. This is also good if you're complacent with being the MRI tech on a Siemens for 30 years. There's nothing wrong with that. It's a great and noble profession that you chose. This is just for people that want to be challenged a little bit more. And I find everybody that's going into it is very excited about it. Like almost being born again into the MRI world. I mean, they get that new heightened like excitement to learn and they want to learn. They're eager to learn. It's not forcing it on them. It's basically just handing it to them, and they're just gobbling it right up.
You need to be a very driven person to actually work on remote.
Yeah.
You need to see it as an opportunity, possibly, rather than being forced to learn something.
Because a lot of people, Julian, I think, hear about remote scanning and they go, okay, scanning from home, easy peasy, right? But it depends on the company they actually get. Because imagine you go to Alpha and they have 4 different platforms or 5. You have to learn those platforms, and then you have to learn the scanners that they use those platforms on. So at the end of the day, you find yourself like in 5 months working, just studying. It's like, this is not the life I wanted, right?
Yeah,
so you need to know what you're choosing. You need to know what
Actually,
you want.
I'm glad you mentioned this, because I think a couple of weeks ago, one of my colleagues approached me and said, do you know that in the US they're already scanning from home? Everyone is scanning from home. I say, oh, not quite sure about that because when we picture about the US, you know, they are always one step ahead, which is true. But I want to ask you, Pete, how quickly you think is spreading remote scanning? Because we don't probably perceive the magnitude, meaning we still feel it like, oh, in the US is already there, so it's going to arrive here at some moment, which is already present actually, and it's getting popular and popular. But if we need to kind of like think about the magnitude of the remote scanning in the US, do you think what is the status at the moment?
I think everybody will be scanning remotely in one capacity or another, whether it's just on site 10 feet away from the magnet that they're using, or in a hub or at home, depending on the company that you work for. It's efficient, it's cost effective when done properly. And I'm not sure, again, in the other parts of Europe and the world, but as far as the United States, the margin for making money in imaging is very low. So they have to be creative. Like this is the only job that you cannot increase your wages because of inflation or anything. It's dictated by the government, and the government's actually been lowering the reimbursement rate. So the owners, you know, have to be a little bit more savvy on how they're going to make money. And this is one way that they can do it. I don't think that's the reason to get into remote. I think it's again, educational purposes, filling the void. You know,
can you just can you just re-explain a little bit about the thing about the salary? Because this is one of the questions that we receive many times. Is it going to affect my salary? Will I be going to be paid less? Will I get more, perhaps scanning more patients? So what is your point of view about this?
So I don't think it's going to be less money for scanning. Maybe some places do that. They say you're saving on the commute or something, but I think it's going to be to wherever, you know, you have to make it appetizing enough for them to do it, right? I mean, so really nobody's going to say, I'll take less money to do it unless they really want to be home, if that's one of the advantages. We don't scan from home per se. We do it in hubs. So you still have to get in your car and you still have to go to work, but you know, it's a nicer atmosphere. I think it's dictated by the where you're scanning and where the hubs are as far as salary is concerned. We try to stay competitive with the area that we're in, is how we do it.
Yeah, understood.
Pete, I have one question as well. Not about science, but about myths and misconceptions about remote scanning. So we hear a lot of myths and misconceptions and things like that. What is the biggest misconception out there about remote operations? Where you feel like everyone is talking about this and it's actually not true?
I get this picture in my mind, almost like a cartoon, that I have my slippers on, I'm in my underwear, petting my dogs, drinking, you know, my coffee in the morning, and watching Oprah on the side there. It's nothing like that at all. I mean, we go into a hub, we sit down, you know, we have our multiple scanners up with our multiple platforms, like you said. It is very intense day. It goes fast though. You know, I can scan for 10 or 12 hours and like look up and I'm 10 hours into it already. I've done 64 or 5 patients, and it's just I feel like I've accomplished something. It's like laying brick after I put that wall up, and you know, I say, oh, look at that, I just did that today. And I could say I accomplished this by scanning, you know, 50 patients today. Or so I think the misconception is that it's lackadaisical, which it's not. It's very intense. The days go by very fast because you're really concentrating on what you're doing. So that's how I feel about that.
About that, short question. Do the remote scanners, the operators, they have breaks? Because you're saying you focus like 4 or 5 patients in a row and you're in a hub. How does it work with breaks? For example, if I'm scanning at the hospital with Julian, let's say, Julian will position the patient, I'll scan this one, but then we probably swap and I position the next, Julian scans, I'm going to grab a coffee, right? When you're working from a hub or working from home, can you picture that idea so people can understand how that day goes for you? Because you're not scanning 12 hours in a row. You need breaks. Who covers for you?
No, yes. So the bathroom breaks are just like if you were on site yourself. I mean, you know, there's a couple minutes in between patients. The sites usually carve out lunchtime. So if you're on time, again, if you're not on time, even if you're not a remote, you're going to just kind of work through lunch just to catch back up, or you do take the lunch and you just make everybody wait, but that's not usually the case. There are times just basically like you do on site. You know, there's times that you can go for a coffee, and there's times that you can't.
Do you have people eating while scanning, like having their lunch at their desk?
If they want to, we provide. You know, they have lunches times. You know, they follow what the site is doing. So there are times that we do get a break. But having said that, I've eaten right at my desk. I've eaten when I was a regular tech though too at my desk.
I'm asking that because I had lunch many times while scanning, so that's why I'm asking.
Well, I think that's primarily where I ate lunch for the last 30 years, is in front of the scanner.
So. We have a question from Manuel. He's a friend of ours as well, a friend of the Everything MRI, and he's asking, what is the first step you have done to open 𝐓𝐴𝐼? So what was the first step to found 𝐓𝐴𝐼? So I think I know where this is coming from, because there's a lot of people thinking about doing a remote hub and creating their own project. So people are interested to know how that works.
So for me, when I really thought about this, and I did some thinking before I approached other people, what did I lack as far as what did I need for this to become successful? I am not a good businessman. And I am not a good networker per se. There's other people that are much better at me. I'm okay at it, but there's much people. So we found people to complement each other. My three partners are detrimental to this. If it wasn't for them, we would not exist. I had the heart of the technology part of it, but I didn't have everything else of it: the business aspect, the marketing aspect, the venture aspect of it. So you really need to surround yourself with people that complement what you do and what you lack. So that's very important in any kind of partnership, right? You don't want to, it's two people. If I did this with another technologist, yeah, we'd be great at the technology part of it, but who's going to handle the business part of it? And it is business. So that's what I recommend. Make sure that you round your team out with people surround you that are totally capable of handling everything.
I agree.
And I've done that. That's one of the luckiest things. Not that I've done it myself. I mean, we're all co-founders, but
yeah, it is a great advice. Yeah, absolutely.
Yeah, we complement each other in what we do. We have a doctor is our MRMD. We have a businessman and a person that owns schools. It's very good at networking.
Peter, I'm quite lucky in this sense because I have someone who is able to do everything. So
oh, you?
I remain surprised every day. So I quite like as like 6 person at the same time.
I was going to say this, that I was lucky with the co-founder that I found, because it's not easy, and most of the times to build a good company, as you say, Pete, we need good people around you. And on top of that, I would say the first thing is to try. Because if you sit at home and wait for things to come to you, they will never happen. So just try and make as many mistakes as you can. And if you're smart enough, learn from the mistakes that other people did. So that's how we are trying to build our own thing. Learn from other people's mistakes so it doesn't hurt us.
And that's what I've told everybody. That's how I learned. I didn't learn from a book. I learned from the mistakes I made.
There you go. Exactly.
Yeah.
So we have one more question, I think, and then will be time to close.
This is very interesting. And if I want to point out, this is a question that came to me, not like in this session, but came to me like outside work. And I think I'm really interested to what Pete is gonna say about this. Go ahead.
You can ask it. No, you
it says, Yoga says, do you feel you have a higher workload now than when you were a regular tech? This is like a very legitimate question, and I'm sure you're gonna reply very transparently.
Actually, no, I really don't. I think the workload has changed. I'm not starting IVs. I'm not getting people changed. I'm not changing coils and cleaning the magnet each time somebody goes in there. That's kind of been delegated to the tech aid, and that's what's so wonderful about the bifurcated role, that they take care of that, and I take care of my craft as far as scanning and making sure that I'm handling the best possible images. I really don't. I feel excited every day I go in now. I mean, it's just like accomplished after scanning all these patients and doing the best I can. Yeah, we still make mistakes. Everybody does,
Yeah.
but we're I find that very fulfilling actually by the end of the day. So no, I don't really feel like if you do something you love, you're not working a day in your life, they say, right? So and I actually love doing this. So
Perfect. Pete, I have one last question for you, and it's not the question we do on podcasts because this is a different format. And one day we'll have you on the podcast. But the question is, and I had this conversation with Julian on the last podcast, where do you see remote scanning in 5 years? Do you think in the next 5 years the world will be different for MRI in terms of remote AI, all of those things? Do you think will be different, or will still be on the path to something?
no, I think it's going to be everybody's going to be doing remote again in one capacity or the other. The big wave is coming right now. It's whether you're paddling to get on the wave or you're going to go over it and just let it go by you. Embrace every new technology, the AI. Embrace the remote. People say you're going to lose your job to AI. You're going to lose the people that will lose their job are the ones that are not willing to work with AI or not willing to do remote in a safe capacity. Those are the people that might lose their job, but I don't think that's really going to happen. I think this is blowing up in front of us as we speak. The wave is here. And I think in the next year to 2 years, you're going to see basically every company doing this one form or another, whether it's a third party or in-house somewhere.
Absolutely. I agree with you 100%. Even if it's just for teaching or support, like Zoe on the previous episode was telling us, I think that's also a very good use for remote operations. Pete, I want to thank you from the bottom of my heart to be here today. It's a massive pleasure to have you once again. We could talk for hours. And I want to tell everyone about the next webinar with Anton. Anton is here actually listening to Pete as well. He did a few questions. Anton is the pioneer of remote scanning. I think he did the first ever remote scan from home. So it's one of those that you don't want to miss. So yeah, if you want to be part of it, just take a picture of that QR code and we'll see you in another week. Pete, once again, thank you so much. It's awesome to talk to you. You're a well of knowledge and experiences and stories. So it's really nice. I hope one day we can sit in London on our podcast studio and talk about life in general as well. Thank you.
I'd be happy to be there. Thank you,
Thank you
guys.
so much.
And this is a
Thank you.
great venue for communication. Thank you for doing it.
Julian, thank you so much once again.
Thank you, everyone. Thank you for attending. Thank you.
Thank you, guys. Bye-bye. Have a nice evening.
Bye.